Organ transplantation is one of the greatest achievements of modern medicine. Surgeons can now replace failing hearts, kidneys, livers, lungs, and even intestines. But while science has made miracles possible, there's a catch. There simply aren't enough organs to go around. Every year, thousands of patients, children and adults, wait on transplant lists, hoping for a second chance at life. For many, that call never comes. The gap between those who need organs and those who donate them is a matter of life and death. This situation compels countries to consider different systems for increasing organ donation numbers. Today, we'll explore how different organ donation systems, an opt-in system versus an opt-out system, shape who becomes a donor, how many lives are potentially saved, and the ethical dilemmas at the heart of these policies. We'll stimulate a critical discussion at the intersection of science, ethics, and society. The core ethical challenge here is rationing scarce resources and determining how to increase the donor pool. So how do we decide who becomes an organ donor? Organ donation policies are crucial frameworks governing the donation of organs for transplantation. They vary significantly across countries. These policies primarily fall into one of two different categories: opt-in and opt-out consent systems. In an opt-in system, individuals must explicitly agree to donate their organs. This model is commonly found in Southeast Asia and the United States. To become a donor in an opt-in system, you must actively register, often by checking a box when you get your driver's license. Your decision is legally binding. This is also known as an express consent policy. In opt-in countries, families can be approached to consent to donation where the wishes of a loved one have never been explicitly stated, or to legally authorize donation where they have. The United States is an example of an opt-in system maintaining a substantial donor rate despite this. Malaysia and Thailand are also opt-in countries. In opt-out systems, everyone is presumed to be a donor unless they explicitly refuse. This practice is prevalent in many European countries. It allows for organ harvesting unless individuals have opted out during their lifetime. This is also known as presumed consent. Opting out would require individuals to state their preference against deceased organ donation whilst alive, often recorded in a national opt-out register. Countries with high rates of organ donation typically favor opt-out consent. Wales, England, and Nova Scotia have recently switched to opt-out, as France and Scotland was planning to in the March of 2021. However, changing to an opt-out system is not nearly as simple or as effective as it might first sound. Often people's first reaction is that it sounds brilliant because millions would be donors by default. But there's an issue with the very presumption of willingness to donate organs. An explicit unwillingness to become deceased organ donors has been detailed internationally. Simply changing the default presumption does not imply they will now be willing to donate. It is also crucial to understand that the difference between hard consent and soft consent policies. Hard consent policies emphasize that the individual's stated preferences as binding with no role of family. In contrast, soft consent policies involve the potential donor's family, whether the country is opt-in or opt-out. In an opt-out scenario, families are often approached to authorize the default of donation. This gives the family an opportunity to ensure that the potential donor's preferences are regarded, especially if the individual hasn't explicitly opted out. In practice, families often still have the final say in many opt-out systems, and these systems are frequently described as soft opt-out. Hard opt-out systems where families are not approached have generally not gained public acceptance and can diminish trust. There's also a policy called mandated choice, which obliges individuals to decide their organ donation preference while alive and have them recorded, often when applying for official documentation such as a driver's license. The question of who decides what happens to a deceased body is almost always defined by the legal framework of the country. This framework dictates how much of an individual's preferences are honored, how much they can be overruled by family, and what type of consent is needed. Ultimately, there is no universally accepted standard for human remains or who can give effect to their rights. You might expect that opt-out systems always lead to more donors. Research indicates that countries with opt-out systems often see higher deceased donor rates. However, the differences may not be statistically significant. This suggests that factors beyond consent legislation, including healthcare system organization and cultural influences, play a critical role in organ donation success. Studies that compare countries with different systems are often flawed because many other factors differ between nations, such as how easy it is to become a donor, cultural norms, and healthcare infrastructure. A contemporary comparison of organ donation and transplant rates across 18 OECD countries found no significant differences in the number of deceased organ donors between opt-out and opt-in countries. However, this analysis noted a significant difference in living donors, with opt-in countries having more living donors per million than opt-out countries. This apparent influence of policy on living donation rates is a subtlety that needs highlighting. Overall, solid organ transplantation numbers, lives saved, were similar, with about 63.6 transplants per million in opt-out countries and about 61.7 per million in opt-in countries. Where opt-in countries lose deceased donors, they gain living donors, and the resultant transplant numbers ultimately average out. Other publications contradict this, with a systematic review concluding that opt-out countries boasted demonstrably greater deceased donor rates than opt-in countries. This review extrapolated that the U.S. could enjoy significantly more transplants annually if it adopted an opt-out system. However, it also noted that if any country were to benefit fully from an opt-out system, it might be the United States, thanks to its existing infrastructure. Consider Spain. Often cited for its high donation rates, Spain does have one of the world's highest donation numbers of deceased donors. But Spanish transplant experts themselves do not consider Spain to be a simple opt-out country. Spain does not have an opt-out register, and families are always approached to authorize donation. These factors contradict the main premises of traditional opt-out systems. Spain's success is attributed to decades of investment in healthcare infrastructure, a national transplant network across hospitals, a vast transplant coordinator network specially trained in requesting donation from families, and a strong culture of trust. The increase in donor numbers started 10 years after the opt-out policy was introduced and is attributed to these initiatives, mainly at the hospital level. In contrast, some countries that switched to opt-out saw little or no improvement. In places where public trust is low, donation rates actually dropped after opt-out laws were enacted, as seen in Chile and Brazil. Brazil introduced a hard opt-out system in 1997, where families weren't asked, causing outrage and leading to its abolition by the end of 1998, within about a year of it going into effect. Chile's opt-out, part of a mandated choice system, initially resulted in a 29% decrease in deceased donor rates and large-scale opt-outs, partly because the population was ill-informed and mistrusted the policy's implications. Chile later amended its law to require a notarized letter to opt out and introduced a reciprocity principle where registered donors get priority for receiving an organ. Meanwhile, in the United States, the opt-in system has seen steady increases in donors thanks to targeted campaigns, education, and best practices. Some regions of the United States have even surpassed opt-out countries in donation rates. Despite high public support for organ donation in the United States, about 97%, an estimated 15 to 45% of deceased donors are lost during the consent process with families. The effectiveness of organ donation systems is also closely tied to educational outcomes and healthcare infrastructure. Higher levels of education and spending on healthcare correlate with increased rates of organ donation. Countries with robust educational net frameworks for healthcare professionals tend to have more efficient systems. Legal structures alone do not guarantee a steady supply of organs. Developing countries face magnified challenges. Many in Africa and Asia have poor data availability, lack governmental commitment, infrastructure, public awareness, and face general mistrust of biomedicine and negatively perceptions of organ donation. They are also vulnerable to organ trafficking, further diminishing trust. Some argue that ethically and legally defensible opt-out policies are difficult to implement in such contexts. Countries like Thailand and Malaysia, though mostly middle or low income, have invested in strengthening their opt-in systems, capacitating hospitals with transplant coordinators, and establishing oversight bodies, leading to increased rates. Ultimately, no single policy is a magic bullet. Success depends on a combination of policy, robust infrastructure, strong public education, public trust, and public engagement. Proponents of opt-out systems often argue that they overcome traditional barriers like perceived religious or social cultural preclusions, lack of education, or challenges in communicating with grieving families. They contend that changing the national default changes the collective psyche towards donation. Some argue that simply making donation the default makes it easier for individuals who are willing but haven't gotten around to registering in an opt-out system. To be sure, shifting the default can have a significant impact on behavior, especially for things people haven't deeply considered. However, simply changing the default doesn't mean people are truly willing to donate. An explicit unwillingness exists across various sectors of society internationally. Also, in soft opt-out systems, which are most acceptable internationally, families are still approached for authorization. This means the barriers encountered when seeking family consent at the bedside, such as unfamiliarity with the deceased's wishes or difficulty making a decision under stress, may not fall away as readily as proponents suggest. The absence of an opt-out register entry isn't necessarily a definitive wish to donate. It could mean the person didn't know about the policy or engage with it. But nevertheless, the claim that opt-out policies in isolation are the key to drastically increased donor numbers is often overstated. Research indicates little difference between opt-in and opt-out when used independently. Careless implementation of opt-out can harm efforts to bolster donations, diminishing trust. Opt-out systems require extensive government buy-in and infrastructural investment for success, which is lacking in many countries, especially developing ones. Furthermore, the enthusiasm for opt-out is sometimes based on the flawed assumption that there are tons of organs out there that just need to be donated. In reality, most unused organs are not usable, and most usable ones are already used. Even in a perfect fix to consent rates wouldn't meaningfully change the fundamental scarcity. Organ donation policies sit at the crossroads of science, ethics, and society. There's no perfect solution. Each approach has trade-offs between saving lives, respecting autonomy, and maintaining public trust. The analysis shows that while opt-out systems are associated with higher deceased donor rates in some studies, this isn't always statistically significant and isn't solely attributable to the policy itself. Countries with successful donation rates, whether nominally opt-in or opt-out, have invested heavily in healthcare infrastructure, public education, transparency, and the dedicated transplant coordination staff who work closely with families. Conversely, poorly implemented opt-out policies or those lacking public trust can backfire. For many countries, especially developing ones, focusing on strengthening the existing system, improving infrastructure, increasing public awareness, and fostering trust might be more effective and economical than a potentially disruptive policy change. Ultimately, overcoming the organ shortage requires a multifaceted approach that addresses barriers at individual, societal, and health system levels. This brings us back to the profound ethical dilemmas. In an opt-in system, individual choice and autonomy are paramount. Donation is viewed as an altruistic act, a generous gift. But does prioritizing individual choice, especially when faced with human inertia or lack of information, ethically justify the thousands of lives lost on waiting lists each year? In opt-out systems, society prioritizes potentially maximizing the number of available organs by presuming consent. This raises concerns about personal autonomy. Is silence truly consent? Does it diminish the sense of altruism if donation feels less like a choice and more like a default or obligation? What happens when public trust is eroded because people fear their rights aren't respected? Furthermore, the reality of soft opt-out systems means families often still have the final say. This adds another layer of complexity as deeply emotional decisions are made under stressful circumstances. Here are the ethical questions I want you to consider. Should society prioritize maximizing the number of available organs even if it means presuming consent? Or should we always prioritize individual autonomy even if it means fewer organs are available and more people die waiting? In systems that prioritize registered donors, if they need a transplant, like the priority rule, does this ethically incentivize donation, or does it make it feel less like a pure gift and more like a transaction? Given that the organ shortage is so vast and the policy alone isn't a silver bullet, what should our ethical focus be? On individual consent or on systemic improvements like better healthcare infrastructure, education, and support of donor families? How would you feel if your organs were donated without your explicit consent? What if someone you loved needed an organ and there weren't enough donors? There are no easy answers to these questions. The science of transplantation is advanced, but the ethical path to increasing donation is complex, intertwined with individual rights, societal values, and systemic capabilities. So what do you think? Should we switch to an opt-out system, or are there better ways to increase organ donation? Share your thoughts in the comments below. Let's keep this critical discussion going. Don't forget to subscribe for more conversations about the ethical frontiers of science and technology. Stay curious, stay critical, and I'll see you in the next video.